Hello, good evening, Dr. Anas and my friends in the world. And I hope everybody are healthy still and doing good job for the dental professionals as well. So this is really my privilege to be invited as a speaker for the DOS D5, am I right? DOS D5 online symposium. I heard that there are hundreds of speakers invited, so it was not easy to decide what kind of topic I need to talk about. So I decided my topic today as the fact and the truth on the alveolar bone regeneration for implants. So placing an implant into the good condition of bone is not a problem, right? It's very easy and very good futures, prognosis, right? But still we have problems on the alveolar bone regeneration. So many ideas, so many techniques, but the result are not stable. So I'd like to start with this slide, which I did in 2004. So as you see, the patient had a very serious periodontitis, and actually all the root were floated. And I extracted and waited for about 4 weeks for the soft tissue healing. And then about 4 weeks later, I opened the flap and placed implant like this. So as you see, the alveolar bone condition has big bone destructions. Actually, the bone destruction was more than apex, tooth apex. So I had to regenerate almost 8 millimeter up to almost 9 millimeter vertically. There was no buccal wall, no palatal wall. So it was like a stick on the floor. Then I grafted with allograft mixed with the synthetic bone graft, and I mixed these bone grafts with whole blood. So whole blood is not like a PRF, but it's stick the bone graft particle into like a stick bone, so easy to handle. If you don't have enough time, this is quite good options. And then I put the Gore-Tex membrane and fixated with the micro screws. This fixation and seamless as a watertight sealing against the natural bone is mandatory when we use Gore-Tex membrane. And I did layered suture following the releasing incision. So soft tissue management is really essential techniques on the alveolar bone regeneration, as you know. And the healing was uneventful. This photo is about 1 month after surgery. So how long we have to wait? I'm going to beg. And in this case, I did almost 9 millimeter vertical bone augmentation without any buccal and lingual bony support. So in this case, how many months we have to wait? So some guys say 6 to 8 months. Some guys say more than 1 year. But, I made the formula for the vertical bone augmentation from my clinical cases. So I decided to wait 1 millimeter for 1 month for 1 millimeter vertical augmentation, plus 3 months for the maturation. So in this case, let's say 8 millimeter, 8 months plus 3 months. So means 11 months, almost 1 year. So we have to wait 1 year in this case. So I waited almost 1 year. So the soft tissue condition was good, and the flap was reopened. And as you see, Gore-Tex membrane under the bone regeneration under the Gore-Tex membrane looks great, right? And this was condition, very good. And then I made a temporary breach on the implants, and 2 months later, final restoration with the gold crown was delivered. So this is intraoral X-rays from the start to the delivery of final restoration. So you can see the maturation of the grafted bone. It's becoming denser and denser. How do you think in this case? How do you feel? So maybe some of you may feel it will be quite difficult, technically difficult. And then you may worry about the instance of complications, immediate or delayed. Right? It can be impacted. There can be some underdehiscence, soft tissue underdehiscence. So many other complications can happen. Right? And then, as I mentioned before, we have to wait quite long. So 1 year delay, the delayed loading is very long to the patient. Right? This is a problem. But this is X-rays afterwards. Up to 4 years, there was nothing. It looks very good. But on the X-ray, after 5 years, I found bone destruction around the last implants. 6 years, and the patients didn't come often. Patient didn't brush well, and he was a heavy smoker. And he didn't come to the office often, so it's not good patients, frankly speaking. And 8 years, as you see, almost half of the alveolar bone around the implants were gone, were destroyed. And he disappeared again and came back to office 14 years later from the augmentation. Then there was nothing to do. We had to remove. So as you see, it was gone. The fixtures were gone, all the regenerative bone was gone. And what's the reason for this problem? Maybe patient hygiene can be a problem. I mentioned the patient didn't brush well and the heavy smoker. But we can assume the quality of regeneration regenerative bone was not good. So weakness of regenerative bone can be another problem. But let's review the patient hygiene. So in this case, I did one implant, single implant at number 37, the second molar at the left mandibular molar. Right? I placed implants without opening flap, one stage, and final restoration. 14 years later, it survived. It not just survived, showed a very good result. And what happens on the upper right area. So in my mind, I cannot say this failure happened because of a patient's neglect of the oral hygiene. So weakness of a regenerative bone. The next option is weakness of regenerative bone. Do you think the regenerative bone is still weak 1 year after bone augmentation? Yes, let's say yes, it was not strong enough. And what's the weakness? Amount of regeneration was not enough? I think not so bad. Shape of regeneration? Maybe the second molar area is not good enough, right? It's not good shape. It shows not good shape. But the second, third implants has a quite good shape of bone. And the maturation, maybe this can be a big problem. So this happens. This made the periimplantitis. Anyway, when I reviewed my previous regeneration, big regenerations, I found that something was wrong. So I did many heavy alveolar bone regeneration with implants, and in most cases, I made this kind of dome-shaped regeneration. I tried, and then I placed implants like this. And then when I removed the cortex membrane and I found that the regenerative bone, it looks great. But in many cases, I had a failure. I had the periimplantitis. Why? Nowadays, I realized It's mainly because of this limited alveolar bone, regenerated bone on the buccal and the lingual side. As you know, Dr. Spray and Dr. Grunder and the famous speakers recommend us to make a bone more than 1.8 millimeter, almost 2 millimeter bone, especially on the buccal side. Otherwise, we will lose some amount of bone. And the initial bone loss can be combined with the bad oral habits like smoking and bad hygiene techniques. Then we have more and more bone loss. So this kind of this shape of bone regeneration is not good. And what is the correct way? This augmentation should be like rectangular, like this, to make more than 2 millimeter bone on the buccal and lingual side. And we need to estimate the shrinkage after removal of the membrane and the follow-up days, right? So we have to have more than 30% of space, more space than the final result. So in this case, we have to have more than 2.5 millimeter space on the buccal side to make this very stable crystal bone response. So this shape of bone amount and the shape of regeneration is very important, one of the key factors. When we have bone defects like this, we call this defect as a dehiscence. Right? So I found my juniors do bone graft like this without the exact concept on the shape of the regeneration. Just to put the bone graft to hide the defects. And then they like to place a collagen membrane which cannot last long enough for the regeneration. So, okay, in this case, the defect can be hidden by the some regenerated bone. So with the pressure from the buccal mucosa or muscles, the result will be similar like this. It looks covered. Right? The defect was recovered by regenerated bone. But actually, this limited amount of regenerated bone cannot survive. So with the time, the crystal bone will go down and down, down. But we cannot see from the intraoral X-ray because we can only see the medial and the distal part of the alveolar bone. So we can find the bone loss only from the CBCT. So this was a big problem. So when I studied with my teachers, so we thought about the biologically designed for ideal regenerations. What is ideal regeneration? So ideal regeneration means it's like same meaning of ideal space management. Of course, we have to choose right bone graft material and right membranes which can last more than 6 months. Anyway, this space management is really essential. Right? This space should be filled with good bone graft in a period. So actually, these numbers and the concept of regeneration was not from my head. It was from these articles, Dr. Yuri Grunder's articles. You can define these articles, and if you read carefully, you can understand what I want to say. The result as a product became like this. So titanium, pre-shaped titanium membrane. And this is the case which I applied this hygiene membrane in 2013. 56 years old, and I placed 10 implants, 8 lower, 2 upper, about 10 years ago. And the old implant was stabilized very well, but the remaining natural teeth had a problem, periodontitis, and we decided to extract all these teeth and then place 6 more implants. All the implant has very good initial stability, and the 5 implants in the posterior were placed into the extraction socket very safely. So these implants will not have problems. But the most important, the central incisor implants had bone defects on the buccal side, lingual side, and the distal side. So this is very aesthetic job, right? So we have to be very careful. We have to make the bone definitely enough bone for the long-term aesthetics. And I try to put as much bone as possible. Of course, you can put more bone, but if you put too much bone, the primary closure will be a problem. And then, if there is too much tangents, you may have underdehiscence, right? So, enough bone, but should be good enough for the soft tissue closure. So I thought that this amount of bone will be enough. And this kind of shape of bone augmentation is important. This is also from Dr. Grunder. But when I placed the pre-designed, pre-shaped IJ membrane into this central incisor implant, I found there was gap. What this gap means, to make ideal regeneration, we have to have a 2.5 millimeter, more than 2.5 millimeter augmentation space for the ideal augmentation. But the space under the IJ membrane means the bone graft is not enough. So I filled the gap with additional bone graft. Then the other area, not covered by IJ membrane, was covered by the collagen membrane. Simple, very simple collagen membrane. And then primary closure was made. To make the temporary crown, I used the fuse abutment, which is very good tools for the temporization. And then 3 months later, still the fuse abutment worked very well. And then removal of IJ membrane is very easy. So make a small incision. No need to make a vertical incision because I didn't fixate the membrane with the tag or micro screw at the bottom. Just I stabilized the membrane with the cover screw on the top of the implants. So very easy. You can find the membrane just underneath the gingiva, and then unscrew the cover screw, and then pull it out. So very easy. And then because of the smallness of the wound, you can just connect the impression cupping and take impression at the same time of the second stage surgery. Then on the lower right photo was delivery day of customized abutments. And then this is 4 months later, and the second temporary crown was delivered on the customized abutments. It looks a little bit long, and then there was no keratinic tissue around the implants, as you see. Keratinic tissue is another additional factor to make the peri-implant tissue stable. But in this case, I wanted to watch what's going to happen. I thought I made enough bone, and there was no keratinic tissue, keratinized attached tissue. So, which problems we can encounter, except the aesthetics. So this is intraoral X-ray. See, the old implant showed very good crest bone response. And I took a CBCT. See, this is a regenerated area, and this is canine implants placed into the socket. The 2 canine implants showed a very good labial alveolar bone shape, and the regenerated area on the number 21 showed more bone regeneration than the extraction socket implants. So I can say the bone regeneration was very good, very stable and successful. 6 months later, X-ray showed very good result, as you see. And 9 months later, so very good responses. And this is 3 years later. Yes, see, look at the gingival response. There was a small redness around the implants, around the prosthetics, right? This may be caused by the difficulty of toothbrushing. But from the X-ray, you can see there was no bone loss. It's not good to maintain this, to allow this small inflammation, but anyway, that was very good. 3 years later, no bone loss. Just 6 years later, so almost same. There's no bone loss. So in my mind, the amount of bone, regenerated bone, is more important than the soft tissue, the keratinized attached to gingiva. Of course, if there is tensions from the frenum and the muscle pull, then we have to take it out. This is another case. And the patient lost 4 molar, 2 premolar, 2 molar from the periodontitis. And the canine is in danger. So it has some mobility and labial gingival recession. And on the distal, there is infrabony defect. And after opening flap, I placed implants like this. So you may think you can place implant a little bit deeper to avoid the bone defects. But if you think the long-term prognosis, so you have to decide how much bone regeneration and how much implant and crown ratio. So I made the imaginary line on this platform, then I placed all the implants at the same level. So as a result, the first premolar has a small defect, the second premolar had quite large extraction sockets, and the first and the second molar has a quite big vertical bone defects. But bone augmentation, in my mind, is all the same for any kind of bone defect. And then after connection of the vertical component, which is Eisen screw, then I put bone graft, same bone graft, mixture of allograft and the synthetic bone with the whole blood, and then I put adequate size of Eisen membrane. Then this is post-op X-ray. It was changed like this. Then about 4.5 months later, in this case, the biggest bone defect was about 3 millimeter vertically. So how many months we have to wait? 3 months plus 2 or 3 months. Ideally, 5 to 6 months. But 4.5 months later, all the intraoral X-ray showed very good image. So I decided to open to the second stage surgery and 4.5 months later. So as you see, the regenerated bone was really amazing. Okay? From the conditions at the lower part, I made a very good shape of bone. Of course, I'm not sure the quality of bone yet, but the shape, at least the shape of bone, regenerated bone, is really looks good, right? And final restoration was delivered. So just to observe the crestal bone response. 4 years later, alveolar bone was very good, right? Even on the first and the second molar, which had the vertical bone, which showed the vertical bone destruction. And one more amazing things. By doing this kind of bone regeneration, see the intra-bony defects on the number 23 was fully recovered. The canine became solid. This is an additional advantage of bone augmentations. And 4 years later, and the lower left was 5 years follow-up. That's good, and no complications, very good. And again, this is quite a difficult case at the lower arch. So this patient was referred to me after 5 failures from the previous augmentations. The previous doctor tried to augment with autogenous bone, allogenous bone, and failed, and the synthetic bone failed. And then finally, he referred these patients to me. And the available bone height under the crest and above the alveolar nerve was about 3 to 4 millimeter. 3 to 4 millimeter. And the concavity was quite big. So concavity is another factor to decide which kind of treatment method can be applied. If there is a flat and the low defects, we cannot use vertical bone augmentation that much. So concavity means the predictability will be quite good. So soft tissue condition was quite bad. It's a very scar tissue because of previous failures. And this is not a good conditions for additional trial of the bone augmentation because it's too tough. And we need to make a soft tissue releasing incision, right? And after bone augmentation, we have to release the soft tissue to make the primary cross easier. But with this scar tissue, the kind of soft tissue management is quite difficult. So vertical bone defect showed. And even there is not enough keratinoid tissue, we need to define where is the center of the existing keratinoid tissue. And we have to make an incision just into the center of the remaining keratinoid tissue. And then they will make a suture much easier and much stronger. Opening flap, and I observed the bone, alveolar bone, and with the help of the previous trial of the bone regeneration, the shape of the alveolar bone was not so bad. It was flat and not very sharpened ridge, fortunately. And then I made the 3 millimeter to 4 millimeter drillings because just underneath there is an alveolar bone, alveolar nerve. And then I placed implants like this and allowed the bone defects. Some implants showed 1 millimeter, less than 1 millimeter. Some implants showed about 2 millimeter vertical bone defects. Right? And then we need to add 1 millimeter more for the future shrinkage, vertical shrinkage. So this is the role. This is the role of agent screw on the top of the implants. Then we have to make a lingual periosteal releasing incision. This is mandatory, right? So we have to make this. And many doctors are scared when they do the lingual releasing incision because of the lingual nerve, right? But if you leave just 1 millimeter of periosteum just above the alveolar bone, it's very rare. You will not have enough chance to meet the lingual nerve. So don't be scared too much. And then same procedure. Allograft, xenograft, plus whole blood, and I put the IgM membrane and some collagenous membrane, mainly because of bad condition of soft tissue. And then layer the suture. I do minimally 2-layer suture, sometimes 3-layer suture. And in this case, I played. Unfortunately, nothing happened. Okay? And then, now, we have to just wait. We have to wait. So, which implant showed the biggest amount of bone defect? The last one. Last one had about 2 millimeter vertical defects. And then I put the one agent screw, 1 millimeter agent screw. In total, about 3 millimeter vertical augmentation should be achieved. So 3 millimeter means 5 months or 6 months. But same with the previous case, the X-ray, intraoral X-ray showed quite good image at 4.5 months later. So, okay, let's try the second stage surgery. Soft tissue condition was not good still. Will not be good in the future also. And I made the incision on the center of the keratinoid tissue, removed the IgM membrane, then I observed the second implants. Right? On the buccal side, you can see the horizontally regenerated bone. This is not very hard, but on the proof, it was quite solid. Then, after healing, I made a customized abutment and a temporary. Temporary should be used quite long enough. Then, final restoration was delivered. So, observe the crystal bone response. See? 4 years later, very good result. 4 years later, no alveolar bone loss. How we can make this kind of very stable crystal bone response? Because we have shape. If I made the bone augmentation with just a dome shape, like the first case, then because of the limitness of the regeneration on the buccal side and the lingual side, this thin regenerated bone will be shrink. Then we will have a bone loss from the crest. But when we made a very good shape of bone on the inner space, inner regenerated bone on the buccal lingual side, there are enough blood supplies. So the crestal bone can be very good result. So this is the shape of IgM membrane made with titanium. And in most cases, it makes a very good result. So compared to the Gore-Tex membrane, IgM membrane has definite benefits. The shape is already decided. So just put the bone graft in underneath. Then you will have a very good quality of bone, very good shape of the regeneration. This is a big benefit. You don't need to think about that. And then, no need to get the watertight sealing. So when we use Gore-Tex membrane, we have to seal the margin with the tack or the micro screw. But it takes time and quite difficult. But with IgM, no need to. The skirt, we call the buccal part and the lingual part as a skirt, lingual skirt, buccal skirt, just a place. So, no need to make tack. And the second stage, because of this, second stage is very easy. Just make a small incision and then put it out. That's enough. If you need to open the flap and to remove the membrane, actually it can damage the regenerating tissues. So the blood supply can be jeopardized. With this kind of benefits, still bone regeneration, bone augmentation have limitations. The first one, primary closure. In some cases, we can do one-stage approach with the IgM membrane, but basically, I do recommend primary closure when you do this kind of bone regeneration. This is much easier, much prognostic. And maturation. Okay, how long we have to wait? Of course, it depends on the bone defect size, the size of bone defects, the shape of bone defects, but who knows? So many articles shows biopsy result, but on the biopsy, it looks very good. But in my experience, even there are very good bone-like tissues, when we remove the membrane, it disappears in a few months or a few years. So we cannot confident with the regenerated bone. That's true. And then still we have to wait quite a long period of unloading period. So this is not good. The patient should wait minimum 4 months, sometimes 6, 7, 8 months. So how we can minimize this waiting period? This is a quite interesting case, and I had some doubts on the current regenerating techniques. This case became a trigger case for the future development. The patient, I placed the 4 implants on the right side, that difficulty, but on the left side, much less bone, right? So I cannot place short implants even. So available bone was 3 to 5 millimeter, and the defect shape was relatively straight. So this is not quite good. And then when I see the intraoral X-ray and intraoral photos, see no keratinic tissue. And again, when I opened the flap, the ridge top was very thin. But despite of this kind of bone defects, I placed implants like this. I don't really think about the pre-existing conditions. I just think the future. What kind of bone regeneration I'm going to make. That is my main ideas when I do surgery. The current regeneration, current bone shape will be regenerated this much, so no need to worry about. But in this case, I worried about the blood supply. Thin ridge on the mandible means limited blood supply, right? Anyway, I put the 1 millimeter Eisen screw and made the holes to promote blood supply. And then I tried the Eisen membrane like this. You can see how much bone I need to regenerate. Okay, then I added the 2 more and put the allograft underneath the Eisen membrane, and after releasing incision, primary course was made. So suture, you have to know how to make a suture. This is key point for the regeneration. The key point on the regeneration is not the bone graft material, it's not the membrane. Actually, this soft tissue closure is the key, the main key for the regeneration. Okay, this is X-ray. So the alveolar ridge became straight. And about 4 months later, when I opened the flap, 5 months later, when I opened the flap, see the regenerated bone. It's really nice, isn't it? I started from these conditions, but I had the regenerated tissue fully filled under the membrane. Then I connected the scannable abutments to make the impression easier. The scannable abutment is very convenient. So when you take impression, no need to remove the healing abutments and connect the impression copying and the impression to take it out and the coming back of the healing abutments. So during this period, during this process, the patients feel very uncomfortable. So in this case, if you can use scannable healing abutments, just to put the small plastic on the top of the healing abutment and just intraoral scan. That's very easy, very comfortable. Then customized abutments were delivered and the final restoration finished. So from here, the process was quite smooth. But when I look close, the alveolar bone response in this case, I found some bone loss started to be happen. So this intraoral X-ray was taken 1 and 4 months later. This was at the second stage, and 2 and 3 months later, 2 years and 3 months later, alveolar bone was a little bit less. Of course, the thread was not exposed. So I don't worry about the prognosis, but anyway, compared to the previous cases, this case was quite odd. So I had a doubt on the condition, the status of regenerative tissue. So what is that? I made the regenerative tissue like this, but how do you think? Is this tissue matured? Nobody will think this is matured enough. Will it be shrunken? Of course. Everybody knows. How much? How much resorption? Oh, somebody say 30%, somebody say more than 30%. And then again, if I maintain that titanium hygiene much longer, not just the 4.5 months, 5 months, If I stay the membrane 1 year, can I have a much better quality of regeneration tissue? I think so. I think so. I think so. How long we have to wait? 6 months? This was 5 months. 12 months? So nobody gave answer on this question. Same with this case. So in this case, the prognosis was very good. No bone loss on the crest, even no 0.5 millimeter bone loss from the crest. What's the difference? So nobody knows still, but we can find some answers from these articles of Dr. Araujo. So Dr. Araujo and his group made a very good quality of bone, right? Very good quality of articles. I believe many doctors, most of you knows this article, right? So he observed the healing of extraction socket. After extraction, how many months we have to wait? How many days we have to wait for the complete healing? Not just the healing, not just the looking healing, right? Complete healing. So in this article, the authors wrote, it took almost 180 days. 180 days in the dog, which means 6 months in the dog. It's same with the 24 months in human. Okay? Because the metabolism of a dog is about 4 times faster than human. So this is extraction socket. So complete corticalization of extraction socket takes about 6 months at a dog experiment. So when we can get completed remodeling with the cortical bone for these regenerate tissues on the buccal and lingual side, this is a big question. Okay? How much shrinkage we should expect during remodeling? Is there any reusable membrane which can last until then? Until then means 24 months, 2 years. I found this slide from my presentation for GBL in 2011. So this was a guideline from the big heroes and the regeneration department. Dr. Buger, 9 months. Dr. Lang, 6 to 8 months. Dr. Buger recommended 7 months. Autogenous block bone case, 7 months. Homname Wang recommended 5 to 6 months. This is all the different, right? Material was different. But in general, they recommended 6 to 8 months for the regeneration. But the defect size and bone quality, different bone material has a different result, right? So I made my protocol like this. 1 month for 1 millimeter regeneration. And I allowed 2 or 3 months for maturation. So this formula worked very well. So when I have a 1 millimeter bone defects, vertical bone defects, how many months I have to wait? 1 plus 2, 3 months. 3 millimeter bone defect, 3 plus 2, or in some case 3 plus 3, so 5 to 6 months. 8 millimeter vertical augmentation, 8 plus 3, 11 months. So it worked very well. And another headache was found on this article. Very famous Dr. Buger's article in 1995. He wrote, an important factor for achieving predictable result is a sufficiently long healing period. As a long healing period is fine, but sufficiently long healing period. What is sufficient? That was my question. 6 months is sufficient, 8 months is sufficient, 12 months is sufficient. Sufficiently long is not a good guideline. Okay? 6 to 8 months is sufficient long? I don't think so. In my feeling, And from the literature of Araujo, he wrote many articles, as you know. I believe the remodeling lasts more than 2 years. So if we want to avoid the shrinkage from the regenerated bone, regenerated tissue, actually the membrane should work more than 2 years. There was no reusable membrane like that. But recently I found this very interesting materials, polycaprolactone. This was used very long. So it started to be used for the medical implants from 1970s by the 3D printing techniques. And it's very interesting. It was used for the facial deformity and eye reconstructions and the skull reconstructions. So no need to worry about the quality of materials. It's good. And then my interest was how long it lasts, how long it can be under the soft tissue, under the gingiva and above the alveolar bone. This is subcutaneous implantation on the dog, on the rabbit. And in this case, as you see, almost 2 years, 24 months later, the membrane was still there. And then there was no inflammatory tissue around the membrane. So that means it can last more than 2 years. And then this is a human biopsy, actually human biopsy after 27 months of subcutaneous implantation. And the tissue, the membrane, becomes like this soft tissue. It was like this. It's a steep at the beginning, but 27 months later, it becomes soft tissue. How good it is, right? Very good, very good. It lasts more than 24 months, then finally it becomes to soft tissue. So this is a double advantage. Then I made this shape, same shape of LT6 iGen. iGen means ideal regeneration. The shape is important for the ideal space management. So shape is same, but material is different. My intention was to maintain the buccal part or lingual part of the membrane. Even I opened the crestal part to make prosthetics. So we cannot wait 2 years, right? So we have to finish the final restoration as soon as possible, but the regeneration should be finished. We have to wait until, and the membrane should work until the final stage of regeneration. The patient had a very serious periodontitis. Then I extracted and waited soft tissue healing, and then opened the flap and placed the implant like this. Look at the bone defects. Buccal bone was gone, but stability was very good. So in this case, how long we have to wait? We can do alveolar bone graft easily, and we can put the very easy membrane, collagen membrane on the buccal side. But I don't believe the quality of regeneration. On the X-ray, it looks good, but I really want to make a complete regeneration on the buccal side, on the buccal side or lingual side of the implants. Then I connect. This is a different shape of iGen membrane. Then this is just a reusable membrane, like plastic. So you can trim, you can cut the membrane very easily. Then just place and snap in. And there are small groove on the top of the iGen screw. Just snap in, and it can be click. Very easy to place. Then place the iGen allograft, non-demineralized allograft, and then primary closure was made. And about 3 months later, I did the second stage surgery. But for the second stage surgery, I don't remove all the membrane. I cut the membrane, coronal part, and remove the coronal part of the membrane. Buccal part was still in the tissue. This is the idea of the new membrane. Then this will work for the maturation of the regenerating tissue. Temporary made, and the custom abutment, and the final restoration was delivered. X-ray, on the X-ray, the regenerating peri-implant bone tissue became more and more radiopathic. So very interesting X-ray. Look at the shape of the regeneration. The left side is the initial stage. When I place implant, it looked like this, and then it showed a very good shape of bone, isn't it? That was ideal. I will do biopsy. I will do re-entry after 3 years. It's not enough follow, but looks very good, no complications. And this is another case last year. The number 45 was gone, and we made a plan for the 2 implants. Okay, this is the second premolar. See, on the buccal side there was bone defect, a little bit. On the first molar, it was already healed ridge, reserved but stable. This is number 45 and 46. And open the flap. The defect was not very serious. And then I placed 2 implants. So first molar showed no difference. The buccal bone was not thick enough, but okay, this is fine. But number 45 had a very thin buccal bone, and about 2 millimeter implant was exposed. So in this case, what kind of regeneration we have to do? And how long we have to wait? That's a headache, right? This kind of a small defect actually is the more headache. So how many months does we have to wait to make a complete regeneration in this case? 3 months? Do we need to wait 3 months? Of course, 3 months is fine. And what kind of membrane you are going to use? Collagen membrane? With the collagen membrane, are you sure we can maintain the buccal regenerating tissue for a long period of time? In my experience, sometimes good, sometimes bad. So I decided to use LT6 iGen. So the LT6 iGen screw is mandatory because we have to estimate the vertical shrinkage. So depending on the size, the shape of the bone defects, you can choose 1 millimeter, 2 millimeter, 3 millimeter. If you place implants deeply into the bone, you need to use a longer iGen screw. Then allograft and iGen membrane was placed, and the primary cross made. I did the primary cross intentionally to see how much bone will be regenerated. And in this case, bone defect was minimum, and I will leave the buccal part of the iGen membrane for the future regeneration. So, second stage will be quite soon. No need to wait long. Just to stabilize the tissue, then I can make a crown. 9 weeks later, 2 months. Open the flap again, and this part was cut. But from the from the photos, you can see the buccal regenerated tissue, and this tissue will be protected from the remaining iGen membrane. Then scannable healing abutments, temporary, and the final restoration in 14 months. So X-ray shows very good. Then look at this. From the CBCT, this is first molar, 46. This is 45. Look at the bone defects. It's better, right? The shape of the regenerated bone had a much better image on the CBCT. I like this image. So if you compare the initial bone conditions, so it looks much better, right? So I don't have enough follow-ups, so I cannot recommend with 100% confidence, but in my mind, in my experience, it has very good future. And this is another case, extracted and placed implants immediately. Then you can see the very thin buccal bone. This thin buccal bone with the bundle bone will disappear in 3 months. No longer than 6 months. So 6 months later, we will have depressions on the buccal side. So I don't want to make that kind of depressions. So just connect the IGEN screw and the bone graft. Actually, any kind of bone graft will work. Then IGEN membrane, 86 IGEN membrane, and the primary closure, and X-ray. Then, so when you remove, so this looks on the major side of the membrane show the floating, right? But if you cut the membrane, you can see the regenerated bone just under the membrane. This is great, right? And the buccal part was still, I left the buccal part, so it will protect the regenerating tissue from the shrinkage, I believe. Then this is another case on the lower. So it's from the failed implant case. The remaining bone was very limited, and up the plate. Maybe this photo is quite familiar to you. So, but to me, this is just a normal, very normal process of augmentation. I tried to augment the vertical defects with the IGEN, LT6 IGEN, but unfortunately, there was only 2 IGEN membrane on the inventory, so I couldn't use the same technique on the second premolar. But the second premolar had a small defect, so I was quite positive. So I decided to use the thin flat LT6 membrane. LT6 IGEN, this is LT6 flat with much thinner thickness. And you can just trim and make the shape with the pinset, or this shape is quite easy to make. Then allograft was grafted, and 2 LT6 IGEN, and on the second premolar I put just a flat membrane, and the primary closure was made. Healing was good. 6 months later, I did the second stage surgery. So the membrane was broken. Anyway, doesn't matter. So you can see the shape of regeneration. Quite good, right? But unfortunately, the least defected implants, which is 45, number 45, it has much less regenerations than the IGEN membrane. Right? The shape is important, then much important. And the thin thickness of the membrane is also important to make sure the regeneration. Anyway, looked good. And then scannable healing abutments. And then it was not easy, almost impossible to make a keratin tissue on the buccal side. So I made the zirconia customized abutment like this. Supragingival margin is invisible area. So supragingival margin, and then temporary, and the final restoration was delivered. So customized abutment, zirconia customized abutment has more advantages than the metal customized abutment because of plaque accumulations. Zirconia customized abutment has much less plaque accumulation, only less than 10% compared to the metal. So I prefer to use zirconia customized abutment at the molar area rather than anterior. 7.5 months later, that's good. And 10 months later, still working good. It's very good. And again, I will show two more cases. But it doesn't have a long-term follow-up, and it doesn't have result even. But just to show, just to look at the surgical technique. I did 4 implants and the IGEN membrane. In this case, I tried to compare metal IGEN membrane and the LT6 IGEN. So I used one by one. But unfortunately, on the day of second stage surgery, I found a fistula. I was surprised. Maybe it was because of the sharpness of a metal IGEN membrane. Anyway, removed IGEN membrane, but even there was a small fistula on the buccal gingiva. The regenerative tissue under the IGEN membrane appeared quite good. And then buccal part was remained, and the coronal part was removed, and the ISQ was 72. So no need to worry about the temporary and the loading. So scalable healing abutment, and then good. Still not finished yet. This is another case in this year. Interesting case. On the left upper arch, very large pneumatized sinus and limited vertical height. And in addition, the thinness, a very thin ridge. Okay, as you see, look at the thinness of the alveolar bone. Sinus was very big. Lateral was not. Lateral is easy to remove, to do the lateral window for the sinus bone graft. That's good. Then okay, this is clinical case. Open the flap. Look at the thin, very thin. We need to do sinus bone graft and IGEN and alveolar bone regeneration with many different techniques. So we have to do 2 techniques. So at the beginning and at the first time, we have to open the flap and make a lateral window and the drilling. During the membrane elevation, I made a small perforation on the sinus floor. But this kind of a small opening makes no problems. Just I put the resorbable membrane to block the perforation and continue the bone graft. So in this case, I use the bone matrix, the synthetic bone graft material only, plus whole blood. Nowadays, I prefer this bone graft material very much. It looks very good. And then it can maintain the space very, very much. On the sinus area, this is really great material. So I put the bone graft into the sinus, and the window was covered with the original bone. Then implant was placed. The stability was very poor. It's not good enough. Then for the 2 implants in the middle, I connected healing IGEN screws. Then this much bone augmentation was tried. In this case, I used the allograft because allograft has more affinity for the bone regeneration than the synthetic bone. Inside of the bone, synthetic bone is good. But outside, I prefer to use allograft or mixture of allograft and the xenograft or synthetic bone. Then put the LT6 IGEN membrane. It looks great, right? Like this. Then primary closure. So I'm waiting the result because the amount of bone regeneration was quite big. So maybe next month I will do second stage surgery with biopsy. So this is the result after surgery. This kind of regeneration, actually, frankly speaking, I don't have enough follow-up. I have about 2 years follow-up so far. But this resorbable membrane, which remains more than 2 years on the buccal side, on the top of the regenerating tissue, I think this will be very promising for the maintenance or the minimizing the shrinkage of the regenerating tissue. That's my idea. But if somebody wants to try this IgM membrane, I hope Dr. Anas can give me the address, so I can send you some. Of course, we don't have a CE registration yet, but only between us. So this is good item, and I used more than several hundred cases so far in 2 years. Then basically no adverse effect. So I'd like to share my experience, and I'd like to share some new materials with you. So this is take-home message from my presentations. The shape of the membrane is really important. So the membrane should be pre-shaped with adequate dimensions for the ideal regeneration. Okay, the ideal space management is the key for GBR. So don't try to make a bend or the shape by yourself. And complete regeneration may need more than 2 years. That's why I prefer LT6 IgM membrane, because I don't need to remove all. Just I remove the crestal part of the membrane, then make a prosthetics, and the buccal and lingual part still remained in the gingiva to protect the regenerating tissue. So at this moment, I'm thinking LT6 IgM membrane can be a candidate, good candidates for the perfect regeneration. When I have several enough cases, which had more than 3 years follow-up, and some more information with the human biopsy, I hope I can share with you once again in the near future. And then, what is the advantage? Actually, even we have 50% of implant surface engaged with natural bone, this is good enough for the loading. Right? But because of a small defect or quite a big defects, we have to wait very long, 6 months, 8 months. So, in my mind, this theory, this trial is very successful. No need to wait long. Just wait enough osseointegration on the surface of the implants engaged into natural bone. Then these parts, defected parts, will work. The regeneration will work, even with the prosthetics procedures. So we may be able to separate the loading from regeneration. Regeneration will last 2 years. Loading can be started in few weeks. That's my idea. This is the end of my presentation today. Thank you very much for your attention. Please stay healthy and hope to see you again soon, face to face. Good luck.